And thank you all. Good afternoon and welcome to VHHA's Annual General Assembly Review webinar. I'm Julie Dime. I'm the Vice President of Government Affairs for VHHA, and I'm thrilled to be here with my esteemed colleague, Brent Rawlings, who is VHHA's Senior Vice President and General Counsel. Just a quick housekeeping note, we are recording this webinar and we'll be sharing the slides with you after the presentation, so no need to take copious notes. We will share these. Today, we will provide you crucial insights and practical guidance to navigate upcoming code changes seamlessly. We'll start with a brief yet comprehensive recap of the 2024 General Assembly session, setting the stage for our deeper dive into the laws set to take effect July 1. These changes have implications for the hospital and healthcare industry, and we'll be breaking down exactly what you need to know. But we won't stop there. We'll also provide a forward-looking perspective on our focus areas and strategic priorities as we prepare for the upcoming 2025 General Assembly session. And if, like you, if the thought of January just creeped into your mind as a little bit too soon, I have that thought as well, but it will be here before we know it. Brent and I are going to turn off our cameras so that we can focus on the presentation. Our email addresses are included on the final slide, and we would welcome any feedback, comments, questions that you have, and we'll after our presentation, and we'll be sure to get back to you if any additional information or questions are needed. All right, so kicking off, we're going to change slides here. We're going to talk through our just quickly our agenda, as I mentioned. I think I mentioned those in the briefing there. And then we'll close up with the budget, and then again, what's coming next. Next slide, please. And we'll go ahead with next slide. So the General Assembly adjourned sine die on March 9th. This was a long session referred to because it's a budget year. But they did not adopt a comprehensive biennium budget as when we adjourned. Unfortunately, but they did set to come back at the reconvene session, and then again on May 13th, and we'll talk a little bit about the budget as we go further. There were over 3,500 pieces of legislation introduced, and mind you, again, just as a reminder, this is a 60-day session, so that does include Saturdays and Sundays, of which they are not in session. So this is a very fast-moving time of year for us. Out of that, 2,280 passed the House and the Senate. The governor set a pretty strong record of vetoes with 153 bills that he vetoed. And I think this might be even a little bit higher now after the reconvene session, and then after time has passed a little bit, he did have the opportunity to veto a few more, but it's right around that number. Very strong outcomes for VHHA and our legislative priorities, and then strong outcomes on defeating problematic legislation, as I'm sure that you all saw and maybe were made aware of throughout the session. We did have several pieces of legislation that were quite challenging that we were able to defeat. No major changes to our priorities during the reconvene session. And then again, the next General Assembly session starts January 8th, 2025. Next slide, please. Well, this session, we had a lot of changes, and you're going to thank me later for the fact that this song is now going to be stuck in your head. So let me just start with sharing this picture on the left-hand side here. It's a pretty remarkable picture. It's really historic. On the left-hand side, you have Lieutenant Governor Winsome Sears. She is the first African-American woman. She's the first woman lieutenant governor. She's also the first African-American woman to be elected statewide. Next to her, you have Delegate Scott, who is the first African-American speaker of the House of Delegates. And then on the other side there, you have Senator Louise Lucas. She's hitting lots of new areas. She's the first African-American woman to serve as President Pro Tem of the Senate, and the first African-American to serve as the chair of the powerful Senate Finance and Appropriations Committee. So I think this is just a phenomenal photo. It also shows you a lot of change that has occurred, certainly in the last 10 to 20 years. In addition to that, with history being made there, we have changes in leadership all across the board. The Democrats took control of the House, and the Democrats maintained control of the Senate. We have 53 new legislators out of 140, and I know that may not sound like a lot, and you think maybe things turn over quickly, but they really don't. And this was a historic year for the number of new legislators that we had. Also new to us, we had a new General Assembly building. So we all had to learn where new offices were. So we all walked around and we would see members, we would see other lobbyists and just the public trying to figure out even where the bathrooms were. So we had quite a lot of newness during this year's General Assembly. I do note there Chairman Mark Sickles, who is the chair of the HHS committee now, which is a committee that we do a lot of work in. He is also a new chairman. Next slide, please. Great. I won't run through all of this, but just wanted to give you a slide here of all the different various committee chairmen and chairwomen who we engage with on a regular basis. And this is the leadership, of course, in both the House and the Senate. I've already mentioned the Speaker and, of course, the Senate Finance and Appropriations Chair and President Pro Tem, Senator Louise Lucas. And then here are the others that we deal with a great deal. I will just note that Senator Ghazala Hashmi is now the chair of the Senate Education and Health Committee, where we also spend a lot of time. So next slide, please. All right, and here is where I'm going to turn it over to my colleague Brent Rawlings to walk you through several different pieces of legislation that will go into effect July 1 or if otherwise noted, perhaps at a later time. So Brent, off to you.
Thank you, Julie, and good afternoon, everyone. Thanks for joining us. There are many more new laws affecting hospitals and health systems than we will have time to cover here today, but the ones we did flag here for you rise to the top as items that could require some action to implement within your operations. That's something we're always looking out for. We do have a full bill list of all items that we may monitor during session affecting hospitals and health systems, as well as helpful bill summaries that we'll make available to you with much more detail. And today our review is really just going to hit on the highlights and draw out some potential actions that could be required to assist you and your teams in implementing the legislation when it comes into effect. Next slide, please. Our first law deals with emergency department staffing. Just by way of background, this was a piece of legislation that was brought at the request of the Virginia College of Emergency Physicians, expressing concerns that without a change to law, emergency departments could be staffed solely by APRNs, PAs, or NPs. And so this emergency department staffing requirement legislation requires the Board of Health to amend its hospital licensure regulations so that any hospital with an emergency department will have at least one licensed physician who is primarily responsible for the emergency department on duty and physically present at all times. Now, current law requires the hospitals to have a licensed physician on call, but doesn't have to be physically present on the premises all times. That's consistent with CMS requirements. This does have a delayed effective date, July 1, 2025, and the regulations, there will be regulations that will be required to be promulgated before it can be implemented by VDH. So in terms of action required, we flagged for you all the need to evaluate any necessary changes to physician staffing for emergency departments and applicable policies and procedures as necessary to accommodate the law. As you think about implementation on this, a couple of things to consider. You'll see that italicized language, what does primarily responsible for mean? Note it does not say physically present in the emergency department at all times. And we highlight that just to say that the intent of the legislation was not to require a physician to be physically present in the emergency department proper at all times, rather to have a physician somewhere in the hospital having assigned responsibility to present in the emergency department if called. Also raises the question about freestanding emergency departments. How would they be handled? For example, could the physician in the main hospital at a different location be sufficient? These are all issues that we'll need to keep tabs on as the regulations are developed. Next slide, please. Another hospital regulatory item regards surgical smoke evacuation systems. Again, with background on this one, this legislation was requested by the Virginia Association of Operating Room Nurses as part of a national effort by AORN. Their perspective is that smoke systems are common and readily available in most facilities, but they're not consistently used. And so this really was just meant to encourage better adoption and practice. And so the law will again require the Board of Health to amend its regulations to require every hospital where surgical procedures are performed to adopt a policy that requires the use of a smoke evacuation system for all planned surgical procedures that are likely to produce surgical smoke. There is a definition here of smoke evacuation system. This is a fairly broad definition, we believe, and it's intended to capture a host of different devices, including smaller handheld devices, battery-operated devices, et cetera. So it really runs the gamut in terms of what can be included. This one also does have a delayed effective date of July 1, 2025, and the regulations will also be required to be promulgated before implementation by VDH. So for action item on this one, we suggest evaluating the need for the development of or any necessary changes to your policies and procedures, the need to purchase or make available smoke evacuation systems for use in surgical procedures, and the need for related training of appropriate staff. Next slide, please. The next two laws that we'll address are directed at ongoing concerns about perceived unfair medical debt collection practices. This legislation here on medical debt collection statute of limitations effectively shortens the statute of limitations for a contract for medical debt that is in writing from 3 years to 5 years to make it really essentially the same as an oral contract, which has a 3-year statute of limitations. So when this law goes into effect, any contract for medical debt, whether in writing or oral, will have a 3-year statute of limitation. It also specifies that the action is barred if not commenced within that time period. And that would essentially create a affirmative defense for the defendant in that case that would reduce the need for the debtor to appear in court. And then it also establishes sort of when the clock starts to tick, and that is established as the due date applicable to the final invoice for healthcare services. The exception to that is if there's a prepayment plan. And for prepayment plan, the clock would run from the date of breach on the prepayment plan contract, and the statute of limitations of 3 years would run from that date of breach. The legislation also specifies that it does not apply to Medicaid services billed under the Medicaid program. And with this one, we've just pretty straightforward notifying your billing departments and financial assistance staff about the new statute of limitations and to sort of address their policies and procedures for debt collection accordingly, and then to evaluate the need for any changes to their medical debt notices and communications to patients. Obviously, with the nuance there around payment plans as well. Something to think about on implementation here with this one is it will certainly come up, which is what is the final invoice in terms of when does the clock start to tick. You start thinking about third-party payment situations and insurance billing, and the question of what is the final invoice certainly comes into play. That's another one that we'll just need to think about and watch as any regulatory activity goes forward. Next slide, please. Continuing with medical debt collection and credit reporting, this legislation prohibits a medical facility, and it's defined as medical facility is defined in the law as any facility for which a certificate of public need is required. Just to be clear, this is not directed at COPN in any way. That's just the definition that they latched onto in the code. Also, health professionals licensed by DHP and emergency medical services agencies from reporting medical debt to a consumer reporting agency. So pretty much anybody in healthcare that is billing patients and doing medical debt collection is prohibited from reporting to a consumer reporting agency. And the legislation also extends that prohibition to collection agencies as well. The sort of the enforcement mechanism for this is that it constitutes a prohibited practice under the Virginia Consumer Protection Act, which comes with it, which has monetary fines assigned under it. So for this one, action required, notify your billing departments and financial assistance staff about the limitations on credit reporting going forward. Next slide, please. Moving into behavioral health, this law arises out of the Arvo Otino incident that occurred here in Richmond. The family of Mr. Otino sought this legislation advocating that patients in similar situations, if they had a family member present or someone advocating for them as part of the psychiatric evaluation process, it could help to avoid or just de-escalate what happened in that unfortunate incident. And so the resolution here from the legislature was to require emergency departments or other facilities where the TDO evaluation is being conducted to allow the individual's family member or legal guardian to be present. And there are many exceptions to that, including if the individual objects or the evaluator or treating physician determines that the present would create a medical, clinical, or safety risk to the patient or healthcare provider, or would it otherwise interfere with patient care. What we've heard from our behavioral health experts is that in many instances, this is already being done or accommodated, but you also have to appreciate that these exceptions could be difficult to parse out. So in some ways, is it codifying existing practice, or is it going a little further or potentially clarifying it? Probably remains to be seen as a practical matter. In effect, that's something that you could just imagine the devil's in the details and figuring out when these exceptions apply. So that's just something we'll have to monitor going forward as well. Action required on this one, notify your emergency department staff and affected providers of the requirement to allow that family member, make them aware of these potential exceptions, developing any changes to your policies and procedures around that to make sure that things go, as well as training to make sure that things go as well as possible. Next slide, please. Another health profession related item, behavioral health / health profession related item we worked on this year is legislation taking further steps to remove any stigma for healthcare providers seeking behavioral health or substance abuse treatment. There has been some confusion in the past under current law about whether or not a voluntary treatment must be reported to the Department of Health, the Department of Health Professions. And so the effort here was to clarify that, and in particular to make clear that to create an exception for cases where there is a voluntary admission. In cases of voluntary admission, if it's determined that the individual is no longer believed to be the provider is no longer believed to be a danger to himself or others within 30 days, the no report is required to be made. So it really sets up a situation where treatment can be obtained and hopefully a positive outcome occurring without the need for any report whatsoever. Again, imagining what impact that would have in reducing any stigma, knowing that you could seek voluntary treatment without having a mandatory report triggered. So that was the intent. No changes under the law regarding involuntary admissions. That's unchanged. Report is still required within 5 days for those situations. The law also added dentists and dental hygienists to the protections under the law, including the civil immunity from civil liability, as well as access to the Safe Haven program to assist providers. And then it also expands the Safe Haven program to allow treatment in outpatient settings, which is something that was limited under previous law. So with this one, action required, evaluate the need for any necessary changes to your policies and procedures and the need for any related training of required reporters and relevant staff. And also, this is just a good one to think about. How do we share this information to make sure that for those that need it, help is available without any stigma and without any potential ramifications in those voluntary cases, whatever we can do to support. Next slide, please. So now we're kind of shifting out of behavioral health into health professions, more specifically, some scope of practice items. First item dealing with physician assistants. This law here will allow physician assistants employed by a hospital in certain facilities, including those operated by DBHDS and FQHCs, to practice without a separate practice agreement if the credentialing and privileging requirements of the facility include a practice agreement that incorporates the components of a practice agreement. So net effect is it allows you to streamline practice agreement requirements. What would otherwise be an individual practice agreement for each physician assistant can be rolled into a single set of statements or elements within your delineation of privileges without the need to have every one of those documented. Just a streamlining approach as an option for providers going forward. Even though not a separate agreement, physician's assistants must continue to practice as part of a patient care team in collaboration and consultation with the patient care team provider. So no change to that supervisory collaborator role. It's simply just a change to the documentation requirements. So action required here would be to evaluate whether employed physician assistant practice agreements should be consolidated into facility credentialing and privilege requirements. Next slide. Shifting now to nurse practitioners and the ongoing journey towards independent practice for those advanced practice registered nurses. This change to law lowers the transition to independent practice for nurse practitioners from 5 years to 3 years. And it also permits a qualified nurse practitioner, that would be one that has transitioned to a practice, to be qualified to practice, to be qualified to serve as the patient care team provider in lieu of a physician. So those independent nurse practitioners could essentially step in the shoes of a patient care team physician and lead that patient care team. That changed the law being in place. And also the law was changed, it changes current law to allow to modify the rules around situations where a patient care team provider is no longer available due to death, retirement, or separation. The current law allows a continuation in those situations without the patient care team provider for 60 days with a 60-day extension. This new law would allow that after 60 days in the extension, a nurse practitioner who has previously transitioned to independent practice and has been in that status for 3 or more years could step into the shoes and be the patient care team provider for that nurse practitioner who no longer meets who no longer has that patient care team physician. So for this one, action item requires notify human resources and medical staff and credentialing departments of the reduced transition to practice period and ability of advanced practice nurses to serve as an alternative to patient care team physician in limited circumstances. Next slide, please. This legislation addresses foreign trained physicians. It expands the current provisional licensure for foreign medical graduates beyond what is allowed under current law, which is more or less limited to different residency sites. It also creates a pathway to full licensure, which is something that was not available under the law. So it permits the Board of Medicine to issue these provisional license to that foreign medical graduate for no more than 2 years, with a subsequent 2-year renewal period if the physician is practicing in a medically underserved area. Then after 2 years of practice under the renewal license in that medically underserved area or health professional shortage area, the physician is eligible to apply for the full unrestricted license to practice medicine. And the one sort of condition around all of this is during that period that specifies that the eligibility for these licenses is contingent upon the applicant demonstrating educational experiential qualifications to the board and being employed with a medical care facility that provides an assessment and evaluation program for physicians licensed in a foreign country. So during that provisional period, it's expected that there is an employment relationship as they work towards full non-provisional licensure. So action required on this one, notify your human resources and medical staff and credentialing departments of the expanded ability of foreign trained physicians to obtain a provisional license to practice in Virginia. Next slide, please. Now shifting into insurance law, this piece of legislation is the product of a multiple year effort. At the request of VHHA in response to prompt payment deficiencies by health plans. It makes needed updates to the Fair Business Practices Act, which is the law that governs the business practices of health carriers in processing and payment of claims. This law, Fair Business Practices Act, has not been materially updated since 1999. So some clearly needed updates here. The updates to the law as of this latest piece of legislation, it changes the claim definition, the clean claim definition, to be more objective and easily interpreted by providers. It requires additional documentation requests and contract documents to be exchanged electronically. It establishes a reasonable and consistent time limit for retroactive denials of claims. It requires carriers to make available to providers information about whether they are covered under a fully insured or self-insured plan. It makes explicit that payment timeliness requirements and related interest provisions apply to payments owed following an overturn of a claim denial. And then it requires carriers and providers to confer before submitting complaints to the BOI unless the carrier is non-responsive. All of these changes to the law were developed as the product of a work group, consensus items agreed to by the Virginia Hospital and Healthcare Association and the Virginia Association of Health Plans and their health plan members. And it was unanimously approved by the legislature. So very welcome additions to the law as a result of this work. Next slide, please. And just wrapping up on the Fair Business Practices Act, just some things to think about in terms of action required, notifying your claims and revenue cycle department of the changes to the laws and the carrier requirements on supplementation requests, making sure that they're abreast of these changes and also making sure that the health plans are following through with them. Along the same lines, monitoring and tracking carrier claims pending and denial activity and raise instances of non-compliance with the clean claim definition and the Bureau of Insurance if needed. And understand and prepare for the new requirements on electronic notifications of contract-related and claims-related communications with carriers. This is also something you'll want to coordinate with your IT folks to make sure that all of the file transfers, other protocols are in place to allow those new requirements that are taking effect in July 25 and 26 to be accommodated going forward. Next slide, please. This legislation follows on an update to the same law in the previous year, last session, regarding continuity of care requirements in instances where a provider is removed from a health plan's provider network. The change to law basically makes a may a shall in the instances of continuity of care provisions going forward. Now, the providers are required to continue to render healthcare services where continuity of care is in place. And that is limited, however, to situations where there is an existing provider-patient relationship, which was not currently addressed in the law. And the definition of existing provider-patient relationship is that the provider has rendered healthcare services to the enrollee or admitted or discharged the enrollee in the previous 12 months. And it also specifies into the law that there's nothing prohibiting the provider from discontinuing treatment under a continuity of care contract under situations where there's misconduct, refusal to follow the provider's policies and procedures, or anything along those lines, so long as they're not being terminated from continuity of care solely on the basis that they were terminated from, that the provider was terminated from the network. So action required on this one is just to understand the new mandatory requirements of continuity of care following termination of carrier contracts, to be aware that those are in place, and to assess that if you should be terminated from a provider contract or withdrawal from a provider contract, these are the rules that will come into play, and just need to keep those in mind. Next slide, please. Last insurance-related item is addressing prior authorization for drug benefits. This one will require carriers to include in their contract provisions that prohibit a carrier from essentially retroactively revoking prior authorizations for drugs, revoking, limiting, conditioning, or modifying those previously approved prior authorization requests that have been scheduled. There are some exceptions to that, which include if the authorization was obtained by fraud or misrepresentation, if the FDA or some other agency has removed the drug from the market or makes some change that limits its use, or if the combination of drugs prescribed would create a drug interaction, or if there is a generic or biosimilar that is added to the prescription drug formulary. Those are all exceptions that would allow some retroactive modification to the prior auth. Otherwise, that prior auth would need to be honored. And so action required on this one: notify the appropriate clinical administrative staff of the changes to care business practices and evaluate the need for any necessary changes to your policies and procedures related to prior authorization requests. Next slide, please. And I believe this is our last law, so thanks for hanging in there. This one addresses prescription drug labeling. This is a piece of legislation that came at the request of advocates for the blind and print disabled. And it will require pharmacies to notify a person that's receiving a prescription drug that an accessible prescription label is available upon request at no cost, and to provide individuals who are blind, visually impaired, or otherwise print disabled an accessible prescription label that meets specified accessibility requirements. It's a long-winded way of saying that if you have a blind, visually impaired, or print disabled individual presenting with prescription, you need to make them aware that they have options. Options include braille labels, specific label readers that are with apps and other things that are available. There are a host of options, and the law doesn't prescribe any one option or alternative for doing that, but some accessibility requirements are going to need to be met going forward if they're not already. This one also has a delayed effective date. It's going to require the Board of Pharmacy to promulgate regulations implementing the provisions of the law no later than April 1, 2025. So it's not going into effect July, but sometime before July 1, 2025, there should be regulations specifying exactly what will be required. As far as action required on this one, notify your pharmacy directors and relevant staff that Board of Pharmacy will be promulgating regulations relevant to the accessible prescription labels. One thing I want to note here is that, at least as we understand at this point, is something to think about is whether or not some of these prescriptions are able to be filled through specialty pharmacies or mail order pharmacies that already have that capability. Something to keep in mind as a possible option going forward. And Julie, that is all I have on the review. I'll turn it back over to you.
Wonderful. Thank you so much, Brent. And again, we are recording and we are also going to send out these slides. So in the event, of course, you have questions, you can certainly email us, but if you need more detailed information. So now let's talk about the budget. As a reminder, the Virginia works on a biennium budget, a 2-year budget cycle. This year was the year to set the next biennium budget, and we have done that. And we ended session with a conference report and a budget that was sent up to the governor. Next slide, please. The governor, and this is again for 25 and 26, we are currently in state fiscal year 24. State fiscal year 25 will begin July 1, 2024. The governor had a lot of thoughts about the General Assembly's budget. And so after March 9th, the adjournment in between March 9th and our reconvene session on April 17th, there was a lot of posturing. There was tax increases in that budget that the General Assembly sent the governor, of which he was adamant that he would not sign a budget that included tax increases. Republicans were certainly upset about the substantial tax hikes, and then also they wanted tax relief for Virginia taxpayers. The Democrats wanted to increase salaries. They wanted a lot more funding in education. And then also wanted to pressure the governor to rejoin the Regional Greenhouse Gas Initiative. So really, it came down to tax hikes and RGGI were the two areas that there was some consternation about. So at reconvene, the governor sent down a lot of amendments. In fact, I believe there were over 200 amendments that the governor sent down on the budget, of which the General Assembly rejected all of them, which of course then set us up for a special session on the budget, which was on May 13th. Now, between April 17th and May 13th, there was a lot of discussion. So the administration and the General Assembly members got together, realizing that they had a June deadline to reach a budget agreement by, or else the government shuts down. And it's just as a reminder, we are not the federal government. We cannot pass continuing resolutions. So we actually have to have a budget by July 1, or the government does actually shut down. So a lot of pressure on the legislature to get a budget, a lot of pressure on the administration. So as expected, May 13th was somewhat of an uneventful day. The compromise budget that the House and the Senate eventually voted on that day was immediately signed by the governor. So the good news is that by the time they got to May 13th, they had all been able to voice their concerns, posture a little bit, but ultimately came together on the 13th of May to adopt a final budget report. The final version mirrored very closely to the conference report, with, again, as opposed to without the two, or with the two exceptions, those key exceptions on taxes, and then RGGI, the Regional Greenhouse Gas Initiative. So by and large, the budget maintained itself, and there was really nothing that changed with the exception of those two areas. The next three slides, so we can start with the next slide here. The next three will review. These slides are going to reflect new funding initiatives or expansions of current programs. If you want more information, I know this is really just a snapshot of the budget items. If there is additional information that you would like to have on any of these topic areas, certainly please let us know. So I'll start with workforce. This has been an area, this and behavioral health have been two areas that we've focused on with the budget. I am pleased to say that $8 million of the over the biennium will go to the Earn to Learn Nursing Education Acceleration Program. This has just kicked off in the last month or so. We received $5 million last year for fiscal year 24 that we could put toward establishing this program. And the great news is that they're going to continue to fund it over the biennium. Great workforce program. There's $14.7 million over the biennium for behavioral health loan repayment program. Again, we're looking for tools that will help us recruit, train, and retain our workforce. This is one of those. $1 million over the biennium to add 10 more GME residency slots, specifically for OBGYN services. $7 million for the nurse preceptor program. $3.8 million for nursing scholarships, loan repayment, incentive programs. Again, all going to help us recruit and retain workforce. Next slide, please. On behavioral health, the state has invested a significant amount over the last several years on behavioral health, starting with the governor's Right Help Right Now initiative. There has been a significant amount of funding really toward the crisis services system. And certainly that was an indication this year that they're going to continue and maintain that funding with an additional $25 million over the biennium to expand and modernize comprehensive crisis services. And of course, this includes all kinds of various different programs, CRCs, CSUs, and even CPEP, the Comprehensive Psychiatric Emergency Program, that many of our members and many of you have done and are considering doing in the future. $9.4 million over the biennium to expand alternative transportation and custody programs for individuals with, under a TDO. We know how important transportation as a whole is for patients, but particularly those under a TDO, to get them to the right place for the right care is extraordinarily important. So we're hoping that this will help. We understand, of course, that if there are not enough transportation providers, that no amount of money that you put toward it is going to solve that problem. But we are hoping that this will be an incentive with more money coming in, that they can incentivize more providers of the alternative transportation service. $10 million for one-time costs for establishing mobile crisis services in underserved areas. This was funding that was approved in September 23. This is continuation of that funding. $30 million over the biennium to combat opioid epidemic in the Commonwealth. I will say that this is opioid funding and fentanyl funding and all the things that kind of under that bucket are all spread out in the budget. So it is incredibly difficult to get a final number. I've done what I could here to get you a number on all the various different programs that are going to support efforts to combat the opioid epidemic. So 30 million is really what I was able to find as it really in the more the health area. It is a lot. So if you need more information about that, want more information on it, really how to potentially receive those funds, or if you've got a program that you think would be eligible for any type of funding, certainly we're happy to guide you through that. 13.2 million over the biennium to fund STEP Virginia. This is the state's comprehensive plan on behavioral health. It is a good plan. It's a solid plan. It needed funding. So the state has done that over the last several years. They're investing even more, which is a good thing. Out of STEP Virginia became the 988 crisis service line, which is, from what we hear, is going extraordinarily well. We are hoping to receive an update, and certainly we'll share that with those of you who may be interested on how the progress is going with that particular 988 service. 6 million over the biennium to expand permanent supportive housing. This is an area that the General Assembly really wanted to focus on. We know that, of course, anybody experiencing any type of health concern or challenge, whether it's behavioral health or chronic disease or whatever it may be, housing is important, and not having a stable environment to go home to after they leave the hospital will certainly almost always land them back in under our care. So that is an investment that we're very proud of, and we do think will help reduce overutilization of the emergency department, amongst other things. The budget includes several additional reporting requirements, most of them related to STEP Virginia, CSB, workforce, and performance. This is one area that we do think needs to have some more oversight. So we are going to be watching these reports very closely. Next slide. So lastly, just wanted to give you a heads up about Medicaid. Of course, we are going through the re-enrollment period. Also, with folks coming off of the Medicaid rolls, DMAS has been hard at work with that and trying to work through that process. There was a lot of uncertainty as we've gone through this. The original budget that was passed from the General Assembly included 150 million in reserve to guard against unexpected increases in the Medicaid program. They were able, with various different upward increases of various different funding mechanisms, they went ahead and in the final budget reduced that to 95 million in reserves. So in the event that the budget forecast came back higher, they would already have those reserves set aside for the Medicaid program. 4.8 million over the biennium for durable medical equipment. These are for folks who are specifically, excuse me, for our more children population, for things like feeding tubes, etc. Then lastly, the caboose budget. So this is what we refer to as the previous fiscal year budget. So this would be referring to the 2023-24 biennium budget. There is an additional 2.3 million that will be directed to the trauma fund. OEMS had some challenges within the department. Some money, some funding got redirected in places perhaps that it shouldn't have. So after they have done a very comprehensive review of those services, they've indicated to us that the trauma fund there was funds, 2.3 million was redirected and should not have been. So the trauma fund is expected to see a $2.3 million in addition to what the trauma fund will receive this year and over the biennium. So that is all for the budget. Next slide, please. So coming up, it never ends. We are now focused in turning our attention to, of course, the 2025 General Assembly session. These items on the left-hand side here under policy are things that we are actively working on 340B. This is also at the federal level. There's a lot of activity on the program. We are looking to see if there are any opportunities for us to benefit even greater from the 340B program. COPN, we're always watching, always active in that space. There is a current working group going on related to COPN. Medical malpractice, same. This was really out of legislation this year that would have removed the cap for those under 10. That is, we were able to defeat that legislation, but certainly no guarantees that would be the case in the future. So we are doing a comprehensive review on medical malpractice and research, putting a lot of time and energy into researching that issue. Behavioral health, always an issue for us. Rural health, the speaker created a rural health and small town subcommittee to see if there were things that could be done to increase access to rural health services. So we are actively engaged in that. And a piece of that, of course, is maternal health. And then labor issues, we're always watching with the split executive branch and the legislative branch. There was not a lot that happened with regards to labor, but that may not be the case as we get closer into the 2026 legislative session. Workplace safety, this is of top of mind for us as we look at potential legislation that would benefit benefit our workforce, but also keep them safe. And then forensic nursing, looking at ways to improve programs there, but also protocols and procedures to make sure that we are adequately meeting a law that was passed a couple of years ago that required us to have documents for planning for if we have to transfer someone out. On the political side, there's no state elections. That's the great news. But there are U.S. House of Representatives. All of our House representatives are up for election. Senator Kane is up for re-election this year. And of course, I certainly don't need to tell you that we have a 2024 presidential race. I'm sure you're all very, very active and involved in. Now, 2025, just want to let you know that once again, we will have our statewide offices up for election. That's the governor, lieutenant governor, and the attorney general. And all 100 members of the House of Delegates are up for election. So we get a little bit of a reprieve this year, but next year we will do this all over again, particularly on our House side and then with our statewide election. So I believe that closes us up for what we wanted to talk today about, but we do want you to save the date. I have a big announcement. I think you're the first to actually formally hear this. Former Congressman Ford will be joining us at our conference in the fall. Harold Ford, he was former congressman from Tennessee. He is now both a Fox News contributor as well as I think a CNN contributor. So you'll be delighted to hear from him. He was very much a Southern Democrat during his tenure in Congress. So he like I said, he is on Fox News, but he does bring a really interesting perspective. I think you'll really enjoy him. This will, of course, be a couple days after the presidential election, so it will be a great time to hear from him and get his insights and perspective. So again, save the date for November 6th through the 8th. This will be back at the Homestead, so we hope that you can join us there. Brent, I'll toss it to you for any closing words.
No, Julie, thank you. I don't have anything further to say other than thank you for listening, and please reach out if you have any questions, if there's anything we can do to help you all.
Great. Thank you so much and enjoy your weekend.